Welcome to the RNSG 1424 Exam 3 Cumulative Lecture. The concepts that we will be discussing are acid-base balance, ethical legal practice, gas exchange, nutrition, and elimination.
Okay, so that brings us to acid-base balance, and I think students have really understood this, but anyway, there's three components to the acid-base balance. There's the pH, the CO2, and the bicarb. Okay? The biggest thing that you want to make sure that you understand about acid-base balance is that they're the two systems of the body that are most valuable for regulation are the respiratory and the renal functioning. Okay? So if there's any alterations in the respiratory or renal, we're more than likely going to see an alteration in our acid-base balance. Okay, so an acid is primarily all the hydrogen ions, okay? A base is a substance that binds to the hydrogen to make water, and the buffer prevents any major changes in the extracellular fluid, okay? So basically what we want is we want a neutral environment. We don't want it too acidic, and we don't want it too alkalytic. Okay, so we want to maintain it with parameters. So how do we do that? We do that by using our two systems, the lungs and the kidneys. Just like when we talked about with shock, we said that because the kidneys shut down, we're not reabsorbing sodium, the sodium bicarb, so that puts us in metabolic acidosis. So this just kind of reinforces this because this is an exemplar of metabolic acidosis would be shock. Okay? Lungs would be the regulators for the CO2 component. Okay, so our lungs help just by increasing or decreasing the rate of respiration to regulate the amount of CO2 in our blood. So the physiological buffers for each component are the lungs and the renal abilities. The lungs help regulate the acid component of the part of the pH balance. So pretty much the lungs are associated with the CO2. How do the lungs help? Well, they either increase or decrease the rate of breathing. So they'll either breathe slower or deeper in response to the pH. Okay? So that is pretty much how the lungs compensate. Renal, what will happen is if for example there's an excessive amount or too little amount, it will either help by excreting the amount of bicarb or help so the kidneys can either produce or excrete the bicarb of whatever is needed. So pretty much they're like the regulatory systems of the body to maintain pH balance. And SaO2 tells you the oxygenation in pulsons, by pulsons. Okay, so I'm not going to review this again, but the steps for blood gas interpretation, first you need to identify if it's acidotic or alkalotic. So anything below 7.35 is acidosis, and anything greater than 7.45 is alkalosis. So big thing with this is that when we look and we identify if it's acidosis or alkalosis, then we need to look at our PaCO2 and then our bicarb. And whichever one is altered, we'll look at it, and we have to look at the direction that each component is going. So for example, if I have a low pH and a low bicarb, then I know that it's a metabolic issue because it's going in the same direction. If I had a low pH and a high CO2, then I know that it's a respiratory component. Okay, so we need to look and make sure first at each piece and identify acidosis or alkalosis, and then look at the bicarb and the PCO2 and see which one is affected and what direction it's going. And so a good acronym that you can use is ROAM. Respiratory moves in opposite direction of pH. Okay? So just think of that, and then you'll always remember. Respiratory alkalosis is when the pH is high and the PaCO2 is low. So when the PaCO2 is low, that means that there's not enough CO2 in the blood. So when we think of patients that are anxious, they're hyperventilating, okay? So a lot of times they're breathing so fast that they're getting rid of all the CO2. So when that happens, usually we'll see it with patients that are anxious, they're hypoxemia, they've had like a salicylate intoxication, they may be pregnant. A big thing with this respiratory alkalosis we can see with pregnancy, because what happens is the uterus pushes up to the diaphragm, and it compresses up to the chest, and it kind of makes it harder for the lungs to expand. So the women that are pregnant, they breathe faster because that's their way of compensating for the anatomical changes that are occurring. Another thing we can also see with respiratory alkalosis if our ventilatory settings aren't changed. So this is why we do ABGs routinely, is because a lot of times if the rates are off and the gases aren't in sync with the vent settings, we may need to change them. Okay, so what do we see with some indications of respiratory alkalosis? You'll see numbness and tingling, inability to concentrate, you'll see loss of consciousness, you'll see tachycardia, and ventricle and atrial dysrhythmia. Okay, so there's a lack of CO2, so you're going to have an alteration, and see here that a lot of times if you see that you're losing CO2, you're going to see that you're going to lose, you're going to have a deficit in your potassium. Okay, so that's important. So when you're looking at in terms of respiratory alkalosis, you're going to see an anxious patient. So what are you going to do? You're going to have them stop and breathe through a paper bag because you want them to rebreathe that CO2, right? You're going to have them calm down. You'll give them anti-anxiety medications. You'll give them Xanax to calm them down. If it's a patient on a ventilator, you'll slow down the rate on the ventilator. Respiratory acidosis is when there's an inadequate excretion of CO2. So there's too much CO2 and there's a low pH. And so what happens, usually we'll see patients with pulmonary edema, aspiration, atelectasis, like if they're in respiratory distress, you'll see that. Sleep apnea, a pneumothorax, anything altering the pulmonary system, you're going to see respiratory acidosis. So typically when we have too much CO2 in our blood, if that happens, it's a vasoconstrictor. So what happens is we're going to have increased pulse, respirations, blood pressure, altered confusion, fullness of the head, and altered level of consciousness. So this just kind of tells you where what respiratory acidosis is, okay? And so in turn, you're going to see hyperkalemia, okay? So you'll see decreased blood pressure with vasodilation, rapid shallow respirations, headache, dysrhythmias due to potassium. So all these different alterations and changes. So what happens when we do this? What do we try to do? The biggest thing is ventilation. So all the conditions we mentioned, they're all connected to the lungs. So what are the things we're going to do? We're going to use bronchodilators to kind of enhance and open up the airway. We can use pulmonary hygiene measures, push fluids, reposition patient frequently. But the most commonly things, these patients are most likely on the ventilator, so you're most likely going to have to adjust your ventilator settings. So if the patient has too much CO2 in their blood, we want them to breathe it off. So we're going to increase their ventilator rate. We're going to keep them in the semi-Fowler's position to kind of help them ease the work of the breathing and just kind of help them blow it off. Because the thing is we want to make sure that we do it slowly, because then it can cause stress to the body. Before I forget, vomiting, gastric suction, and pyloric stenosis. Pyloric stenosis is where there is a narrowing of the pyloric sphincter, and it makes it harder. Usually the patients have frequent emesis. They have frequent emesis, and they lose a lot of electrolytes. So with pyloric stenosis, usually they'll need corrective surgery. So they'll always, in before they're diagnosed, their ABG will come back with metabolic alkalosis. Okay. Some of the things that we want to do is we want to monitor intake and output because they are vomiting, so they're losing electrolytes, and we're just going to push them with fluids. Okay, we'll give them normal saline fluids because we want to hydrate them, and we also want to make sure if there's a deficit in their potassium levels that we give them potassium chloride. Also, a lot of times too, what we'll do is we'll have H2 receptor antagonists, which are Tagamet, which kind of help us hold on to the hydrochloric acid so we don't lose it anymore. And so this is just a little picture of the metabolic alkalosis here. For metabolic alkalosis, you're going to see a pH that is elevated and a bicarb that's elevated because metabolic moves in the same direction as pH. So what you're going to be seeing is restlessness, dysrhythmias, compensatory hypoventilation. Sometimes when your metabolic component is low or high, or when your respiratory component is low or high, sometimes it'll cause the opposite factor to get involved to compensate for either the decrease in the component or the increase in the component. So it's very likely that you might see that in a compensation effect as far as when you're looking at acidosis and alkalosis. But that'll be taught further in detail in advanced courses, but what you want to understand is the basics, okay? And so that's what that means. Compensatory hypoventilation is a way of the body responding to the low metabolic component. Okay? So you'll have confusion, nausea, tremors, and you'll have hypokalemia. Okay? So in some cases where a patient is maybe severely vomiting or in use of diuretics and fluid loss, if you're excessively deep suctioning a patient that maybe has a trach or is possibly is ventilated, you could see metabolic alkalosis with your patient. Metabolic acidosis is when there's a low pH and a low bicarb. And usually I have this reversed, I'm sorry, but usually when we have a loss of bicarb, it's usually diarrhea, if we're having too much output, or if the patient is like NPO and on fluids or on parenteral fluids and they're not getting enough sodium bicarb, or if we're giving too much chloride in our TPN, it can alter that. And so a lot of times signs and symptoms, they'll see headache, confusion, drowsiness, increased respiratory rate, nausea, and vomiting. Okay, so what do we do for metabolic acidosis? The biggest thing is what we do is first we have to see what the cause is. So if it's because we have too much chloride in our TPN, we're going to adjust our TPN. If it's a patient that is in shock and is in metabolic acidosis, we're going to give sodium bicarb. Okay, and then we're going to monitor potassium because we know that with sodium bicarb we're going to have alterations in potassium levels. A good thing to remember too with metabolic acidosis is that we're going to touch on this, but we typically see Kussmaul breathing because when our body becomes, when we see metabolic acidosis, our body isn't reabsorbing the potassium, and so a lot of times if our kidneys are shutting down, they're not reabsorbing not the potassium, they're not reabsorbing the bicarb, and so what happens is the respiratory component gets involved, and so the breathing, the Kussmaul breathing occurs. Okay, and so it makes them breathe a little bit more shallow so that it'll kind of compensate and create hyperventilation. Hyperventilation. Okay, diabetic ketoacidosis. The biggest thing we want to know about diabetic ketoacidosis is that it's the lack of insulin. Okay, diabetes is the lack of insulin, but DKA is worse because there is just no sufficient amount of insulin for the intake that's occurring. Okay, and so what happens is we see severe hyperglycemia, and what happens is that because of the lack of insulin, we see dehydration and acidosis, and we'll explain about this. Okay, so how does DKA occur? Okay, so what happens is the body is lacking insulin. And so what happens is that the cells are not getting the sugar that they need. The sugar staying in the extracellular fluid. And so what happens is the body doesn't recognize that the fluid is, not the fluid, the body doesn't recognize that the sugar isn't going into the cell because of the insulin, it's just staying in the extracellular fluid, that the liver starts compensating and producing, releasing glycogen, okay? And glycogen is used when we don't have, when we're going like into a hypoglycemic state, our liver compensates and releases sugar that's stored to kind of help and restore our blood sugar. So with DKA, our body is not recognizing that due to the insulin, the lack of insulin, our cells aren't getting the sugar. So let's get the liver involved. The liver gets involved, releases the glycogen, and what's released with the glycogen is what's called a ketone, a keto acid. Okay, so what happens is because the cells are compromised of the sugar, the body tries to get rid of the excessive amount of glucose in the vasculature. So then the kidneys start urinating, the kidneys start producing urine, and so we see polyuria. And so because of the polyuria, we see dehydration. Okay? So when the fatty acids are converted into the ketone bodies, which is what the liver helps us do, due to the lack of insulin to take those ketone bodies into the cell, they stay in the blood. Okay? And so this makes the body acidotic, which leads to metabolic acidosis. So eventually what we end up seeing is metabolic acidosis, and with compensation of the respiratory system by breathing, by initiating Kussmaul breathing. Okay, so due to the metabolic acidosis, the potassium is not able to get, well, actually not even due to the metabolic, it's due to the lack of insulin. Potassium isn't able to get into the cell because it's housed into the cell. So a lot of times we'll see hyperkalemia with DKA. So we'll see ketones in the blood and the urine. We'll see electrolyte imbalances because we're losing a lot of fluid, and so we're essentially being dehydrated. Okay. We'll have low blood pressure because we're losing fluid. We're having polyuria, and patients are going to feel as great. They're going to feel very tired. They're going to have, feel discomfort, and they'll be nauseous and vomiting because of the high glucose. Actually, not because of that. Because of the low glucose in the cell. Because the glucose isn't in the cell, it's in the vasculature. So what do we do for the DKA? Because we're losing a lot of our fluid through urine, we're going to what? Replenish our fluid and our electrolyte balances. A lot of times we give them drips of insulin because the insulin will help regulate and put the sugar into the cell, and it also will help carry the potassium into the cell. A lot of times when we give the insulin and the fluid, acidosis corrects itself. So we want to make sure and pay really close attention to the acidosis portion of it, because usually it'll correct itself once we give the insulin and the fluid. We're going to monitor blood glucose levels. Because of the high glucose levels, we want to make sure, and the alteration, the compensation to our kidneys, we want to make sure we're checking the renal function. We also want to check for cardiac and electrolyte levels. Specific cardiac EKG, we want to be checking the potassium levels, because remember, potassium is housed in the cell, and so there's no insulin to carry it in there. We're going to be checking vital signs, lung assessments for any indications of fluid overload, because we are giving them fluid resuscitation.
In the concept ethical legal practice, the exemplars are criminal law, civil law, American Nurses Association Code of Ethics, patients' rights, and informed consent. The concept of ethical legal also has the exemplars criminal law, civil law. A crime is a violation punishable by the state, whereas a tort is subject to action in a civil court, with damages usually being settled with money. In a crime, criminal law is in most cases statutory law. Crimes are classified as misdemeanors or felonies. A misdemeanor is a less serious crime than a felony. Misdemeanors are commonly punishable with fines, imprisonment for less than 1 year or both, or with parole. A felony is punishable by imprisonment in a state or federal penitentiary for more than 1 year. Torts may be intentional or unintentional acts of wrongdoing. A person committing an intentional tort is considered to have knowledge of the permitted legal limits of his or her words or actions. Unintentional torts are referred to as negligence. A person who fails to initiate proper precautions to prevent patient harm, like falls or skin breakdown, is subject to the charge of negligence. Within intentional torts, you have assault and battery. Assault is a threat or an attempt to make bodily contact with another person without that person's consent. Battery is an assault that is carried out and includes willful, angry, and violent or negligent touching of another person's body or clothes, or anything attached or held by that other person. Defamation of character is an intentional tort in which one party makes derogatory remarks about another that diminish the other party's reputation. Slander is oral defamation of character. Libel is written defamation. Invasion of privacy includes all information about a patient being considered private or confidential, whether it be written on paper, saved on a computer, or spoken aloud. This includes their name and all identifiers such as address, telephone, fax number, social security number, and any other personal information. It also includes the reason the patient is sick or in the hospital, office, or clinic, the treatment he or she receives, and information about past health conditions. False imprisonment is unjustified retention or prevention of the movement of another person without proper consent and can constitute false imprisonment. For example, only a reasonable amount of restraint should be used in circumstances that warrant it. Fraud is willful and purposeful misrepresentation that could cause or has caused loss or harm to a person or property. Within unintentional torts, negligence and malpractice is libel. Negligence is defined as performing an act that a reasonably prudent person under similar circumstances would not do, or conversely, failing to perform an act that a reasonably prudent person under similar circumstances would do. Malpractice is the term generally used to describe negligence by professional personnel. We have elements of liability. Liability involves 4 elements that must be established to prove that malpractice or negligence has occurred. 1, duty, 2, breach of duty, 3, causation, and 4, damages. Last, we have standards of care. Whether negligence has occurred depends on a standard of care, what a reasonably prudent person would or would not have done under similar circumstances. All nurses are responsible for following the standards of care for their particular areas of practice. With the concept ethical legal practice is the exemplar civil law. Civil law regulates the relationship among people. Civil law includes laws relating to contracts, ownership of property, the practice of nursing, medicine, pharmacy, and dentistry. With statutory law, there is a legislative body that enacts it. Statutory laws must be in keeping with both the federal constitution and the state constitution. Nurse Practice Acts are an example of statutory laws. The legal source of rules of conduct for nursing is Nurse Practice Acts. As a profession, nursing is accountable to society. Nursing has identified its standards of accountability through formal codes of ethics that explicitly state the profession's values and goals. The American Nurses Association established a code of ethics. There are 9 codes of ethics. First, the nurse in all professional relationships practices with compassion and respect for the inherent dignity, worth, and uniqueness of every individual, unrestricted by considerations of social or economic status, personal attributes, or the nature of health problems. Second, the nurse's primary commitment is to the patient, whether an individual, family, group, or community. Third, the nurse promotes, advocates for, and strives to protect the health, safety, and rights of the patients. Fourth, the nurse is responsible and accountable for individual nursing practice and determines the appropriate delegation of tasks consistent with the nurse's obligation to provide optimum patient care. Fifth, the nurse owes the same duties to self as to others, including the responsibility to preserve integrity and safety, to maintain confidence, and to continue personal and professional growth. Sixth, the nurse participates in establishing, maintaining, and improving healthcare environments and conditions of employment conducive to the provisions of quality healthcare and consistent with the values of the profession through individual and collective action. 7, the nurse participates in the advancement of the profession through contributions to practice, education, administrations, and knowledge development. 8, the nurse collaborates with other healthcare professionals and the public in promoting community, national, and international efforts to meet health needs. Last, the profession of nursing, as represented by associations and their members, is responsible for articulating nursing values, for maintaining the integrity of the profession and its practice, and for shaping social policy. Within the concept ethical legal practice is the exemplar patient rights. The American Hospital Association developed a Patient's Bill of Rights in 1972, which has been revised in 2003 and is now named the Patient Care Partnership. It addresses the expectations, rights, and responsibilities of the patient while receiving care in the hospital. It ranges from high-quality patient care to helping prepare the patient and their family for when they leave the hospital. The legally prudent nurse must be familiar with how different institutions and professional groups define patient rights and responsibilities. The Patient Care Partnership, understanding expectations, rights, and responsibilities, is including what to expect during your hospital stay, meaning the patient's hospital stay. This will be high-quality hospital care, a clean and safe environment, involvement in their care, discussing their treatment plan, understanding their health care goals and values, understanding who should make decisions when the patient cannot, protection of their privacy, helping prepare the patient and their family for when they leave the hospital, and helping the patient with their bill and filing insurance claims. Within the concept ethical legal practice, informed consent is an exemplar. Every person is granted freedom from bodily contact by another person unless consent is granted. In most states, you must be 18 to legally provide medical consent. States vary in the types of medical treatment they allow minors to authorize without their parents. The consent must be written, designated for the procedure to be performed, and signed by the patient or person legally responsible for the patient. A nurse should make sure that the patient's understanding of all the information they need to validly consent to or refuse what is being proposed should be explained to them. If patients do not speak English, they require the services of a translator. Obtaining informed consent is the responsibility of the person who will perform the diagnostic or treatment procedure or the research study. Your role as a nurse is to confirm that a signed consent form is present in the patient's chart and to answer any patient questions about the consent. In some cases, you may be responsible for having a patient sign the consent form after a physician has explained the procedure, its risks and benefits, and alternative treatments to the patient. Documenting the consent process with a printed consent form should not be confused with the actual explanation given to the patient and the informed consent itself. As a nurse, they will sign the consent form as a witness to having seen the patient sign the form, not as having obtained the consent themselves. Although there may be times when a nurse may be responsible for having a patient sign the consent form, in all instances, the nurse is responsible for answering any questions the patient may have and for making sure that the signed consent form is on the patient's chart. If the nurse determines that the patient is unsure or has questionable understanding, The nurse is responsible for notifying the person who had obtained the consent about the situation so that the person can clarify or re-explain the information. To help you understand informed consent, in the Taylor ebook, Box 7.5, there is a checklist to ensure informed consent. The first part is disclosure, where the patient has been informed of the nature of the procedure, risks, alternatives, and that no outcomes can be guaranteed. Second is comprehension. The patient can correctly repeat in his or own words that for which the patient is giving consent. Fourth is competence. The patient understands the information needed to make the decision and is able to reason in accord with a relatively consistent set of values and can communicate a preference. Fourth is voluntariness. The patient is voluntarily consenting or refusing. Care has been taken to avoid manipulative and coercive influences. With the concept of gas exchange, the exemplars are asthma, chronic obstructive pulmonary disease, pneumonia, aspiration, and tuberculosis.
Asthma is a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and mucus production. This inflammation ultimately leads to recurrent episodes of asthma symptoms, which include cough, chest tightness, wheezing, and dyspnea. The underlying pathology in asthma is reversible diffuse airway inflammation that leads to long-term airway narrowing. This narrowing, which is exacerbated by various changes in the airway, includes bronchoconstriction, airway edema, airway hyperresponsiveness, and airway remodeling. Now, there are age differences between the adult and the child. The children have narrow airways, which causes a greater increase in airway resistance, which is actually the effort or force needed to remove oxygen through the trachea to the lungs. Children's airways are smaller than adults, and they also have increased friction and resistance increase as air passes through the airway. Oxygen consumption in children is higher due to the metabolic rate being higher. And children also have fewer glycogen reserves, which means their muscles fatigue faster. There are triggers that elicit an asthma exacerbation. Things like smoke, dust mites, pet dander, cockroaches, indoor molds, pollen, and air pollution. The management of asthma is utilized with medications. Correct administration of drugs is a major factor in success. Inhalation of drugs is preferred to avoid systemic side effects. Metered dose inhalers and dry powdered inhalers and nebulizers are devices used to inhale the medications. A metered dose inhaler with a spacer is easier and improves inhalation of the drug. Dry powder inhalers require less manual dexterity and coordination. Medications are anti-inflammatory drugs. Corticosteroids, such as beclomethasone, suppresses inflammatory response. Inhaled form is used in long-term control. Systemic form to control exacerbations and manage persistent asthma. It reduces bronchial hyperresponsiveness and decreases mucus production. Mast cell inhibitors, such as cromulin or Intol, inhibit IgE-mediated release of inflammatory mast cells. A long-term administration can prevent and reduce bronchial hyperreactivity. It is effective in exercise-induced asthma when used 10 to 20 minutes before the exercise. Leukotriene modifiers, such as montelukast or Singulair, blocks actions of leukotrienes, which are potent bronchoconstrictors. It has bronchodilator and anti-inflammatory effects. It is not indicated, though, for acute attacks. Bronchodilators include the beta-2 adrenergic agonist. There are two kinds, short-acting relief and long-acting for control. First drug usually given during an acute attack would be the short-acting for relief, which is albuterol. It's effective for relieving acute bronchospasm. The onset is in minutes and duration of 4 to 8 hours. It prevents the release of inflammatory mediators from mast cells. There is also methotrexate, which is theophylline. It is less effective long-term bronchodilator. It alleviates early phase of attacks but has little effect on bronchial hyperresponsiveness, and it has a narrow margin of safety. We also have anticholinergics, which is Atrovent. Those block action of acetylcholine, usually used in combination with a bronchodilator. The most common side effect is dry mouth. Other medications that can be used are decongestants, antitussives, and expectorants. Chronic obstructive pulmonary disease is a preventable and treatable, slowly progressive respiratory disease of airflow obstruction involving the airways, pulmonary parenchyma, or both. COPD may include diseases that cause airflow obstruction, like emphysema and chronic bronchitis, or any combination of these disorders. Clinical manifestations are chronic cough, sputum production, dyspnea. Long-term clinical manifestations are a barrel chest and clubbing of the fingers. Interventions include teaching to breathing exercises, which is pursed lip breathing, diaphragmatic breathing, teaching to pace activities, teaching self-care activities, exercise, oxygen therapy, nutrition, and coping measures. Medications that are utilized for COPD are bronchodilators and corticosteroids. Bronchodilators receive bronchospasm by altering smooth muscle tone and reducing airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. Aspiration pneumonia can be very complicated. There are risk factors for adults. Difficulty swallowing or dysphagia increases with age and is a major healthcare problem in older patients. Normal aging alters some aspects of swallowing function. Dysphagia is a frequent complication of stroke and a significant risk factor for that development of aspiration pneumonia. It can be life-threatening. Dysphagia is caused by interruption or dysfunction of neural pathways. If a patient aspirates food or fluid, it is the most serious complication and can also occur in the absence of coughing or choking. Decreased consciousness, the decreased cough reflex, epiglottal reflex, tracheal intubation, seizures, head injury, drug intake, general anesthesia, gastroesophageal reflux disease, NG tubes, and stroke are risk factors in adults for aspiration pneumonia. Children also can have aspiration pneumonia. Their risk factors are small for gestational age, infants fed in a supine position, bottle propping, and any small objects that can fit through a toilet paper roll is a risk factor for children to aspirate and then have aspiration pneumonia. Key points of aspiration pneumonia are first the prevention. Assess patients that are at risk for aspiration pneumonia and identify them to prevent the aspiration. Have early identification. Nurses should be vigilant for the clinical manifestations that indicate pneumonia and should be reported quickly so that treatment may be initiated early. The activation of the immune response interferes with oxygen as it diffuses from the alveoli to the pulmonary capillary, and carbon dioxide diffuses back into the atmosphere. The process of ventilation can be altered when patients are experiencing pain or conditions that allow the aspiration of gastric contents.
With the concept gas exchange, the exemplar tuberculosis will be explained. Tuberculosis is an infectious disease that primarily affects the lung parenchyma. It also may be transmitted to other parts of the body, including the meninges, kidneys, bones, and lymph nodes. The primary infectious agent, M. tuberculosis, is an acid-fast aerobic rod that grows slowly and is sensitive to heat and ultraviolet light. Tuberculosis spreads from person to person by airborne transmission. An infected person releases droplet nuclei through talking, coughing, sneezing, laughing, or singing. Larger droplets settle, smaller droplets remain suspended in the air or are inhaled by a susceptible person. The susceptible person inhales that mycobacterium and becomes infected. The bacteria are transmitted through the airways to the alveoli, where they are deposited and begin to multiply. The bacilli are also transported via the lymph system and bloodstream to other parts of the body, like kidneys, bones, cerebral cortex, and other areas of the lungs, like the upper lobes. The body's immune system responds by initiating an inflammatory reaction. Phagocytes engulf many of the bacteria, and tuberculosis-specific lymphocytes lyse or destroy the bacilli and normal tissue. This tissue reaction results in the accumulation of exudate in the alveoli, causing bronchopneumonia. The infection usually occurs 2 to 10 weeks after exposure. The granulomas, the new tissue masses of live and dead bacilli, are surrounded by macrophages, which form a protective wall. They are then transformed to a fibrinous tissue mass, the central portion of which is called a gone tubercle. The material becomes necrotic, forming a cheesy mass. This mass may become calcified and form a collagenous scar. Active disease may develop because of a compromised or inadequate immune system response. Active disease may also occur with reinfection and activation of dormant bacteria. In this case, the gone tubercle ulcerates, releasing that cheesy material into the bronchi. The bacteria then become airborne, resulting in further spread of the disease. Then the ulcerated tubercle heals and forms scar tissue. This causes the infected lung to become more inflamed, resulting in further development of bronchopneumonia and tubercle formation. To determine whether a person has been infected with the tuberculous bacillus, we will administer a tuberculin skin test, which is called the Mantow method. It is used widely in screening for latent M. tuberculosis infection. Tuberculate bacillus extract and purified protein derivative is injected into the intradermal layer of the inner aspect of the forearm, approximately 4 inches below the elbow. What's important is to document the site, the antigen name, the strength, the lot number, the date, and the time of test. The test result is read 48 to 72 hours after injection. Tests read after 72 hours tend to underestimate the true size of the induration. Induration is also considered the hardening. A reaction occurs when both induration and erythema are present. After the area is inspected for induration, it is lightly palpated across the injection site from the area of normal skin to the margins of the induration. The diameter of the induration, not the redness, is measured in millimeters at its widest part, and the size of the induration is documented. The size of the induration determines the significance of the reaction. A reaction of 0 to 4 millimeters is considered not significant. A reaction of 5 millimeters or greater may be significant in people who are considered to be at risk. It is defined as positive in patients who are HIV positive or who have HIV risk factors and are of unknown HIV status, and those who are close contacts of someone with active TB, and in those who have chest x-ray results consistent with TB. An induration of 10 millimeters or greater is usually considered significant in people who have normal or mildly impaired immunity. A significant reaction indicates past exposure to M. tuberculosis or vaccination with Bacilli Clement Gerine, which is BCG vaccine. The BCG vaccine is given to produce a greater resistance to development of tuberculosis. It is effective in up to 76% of people who receive it. The BCG vaccine is used in Europe and Latin America, but not routinely in the United States. Pulmonary tuberculosis is treated primarily with anti-tuberculosis agents for 6 to 12 months. A prolonged treatment duration is necessary to ensure eradication of the organisms and to prevent relapse. In current tuberculosis therapy, 4 first-line medications are used: isoniazid, rifampin, pyrazinamide, and ethambutol. Recommended treatment guidelines for newly diagnosed cases of pulmonary tuberculosis have remained consistent since 2003 and have two phases, an initial treatment phase and a continuation phase. The initial phase consists of a multi-medication regimen. All medications are taken once a day and are oral medications. This initial intensive treatment regimen is administered daily for 8 weeks. The continuation regimen lasts for an additional 4 or 7 months. People are considered non-infectious after 2 to 3 weeks of continuous medication therapy. The total number of doses taken, not simply the duration of treatment, more accurately determines whether a course of therapy has been completed. The nursing management includes promoting airway clearance, advocating adherence to the treatment regimen, promoting activity and nutrition, and preventing transmission. In promoting airway clearance, increasing the fluid intake promotes systemic hydration and serves as an effective expectorant. The nurse instructs the patient about correct positioning to facilitate airway drainage. The multiple medication regimen that the patient must follow can be quite complex. Understanding the medications, schedule, and side effects is important. The nurse educates the patient that tuberculosis is a communicable disease and that taking medications is the most common effective means of preventing transmission. The major reason treatment fails is that patients do not take their medications regularly and for the prescribed duration. This may be due to side effects or the complexity of the treatment regimen. The nurse educates the patient to take the medication either on an empty stomach or at least 1 hour before meals because food interferes with medication absorption. Patients taking isoniazid should avoid foods that contain trimine and histamine. Those have tuna, aged cheese, red wine, soy sauce, and yeast extracts. Because eating them while taking isoniazid may result in a headache, flushing, hypotension, lightheadedness, palpitations, and diaphoresis. Patients should also avoid alcohol because of the high potential for hepatotoxic effects. In addition, rifampin can alter the metabolism of certain other medications, making them less effective. Medications like beta blockers, oral anticoagulants like warfarin, digoxin, quinidine, corticosteroids, oral hypoglycemic agents, and oral contraceptives, theophylline, and verapamil. To promote activity and adequate nutrition, the nurse plans a progressive activity schedule that focuses on increasing activity tolerance and muscle strength. Anorexia, weight loss, and malnutrition are common in patients with tuberculosis. The patient's willingness to eat may be altered by fatigue from excessive coughing, sputum production, chest pain, generalized debilitated state, or cost, if the patient has few resources. In preventing transmission of tuberculosis infection, the nurse carefully instructs the patient about important hygiene measures, including mouth care, covering the mouth and nose when coughing and sneezing, proper disposal of tissues, and hand hygiene. Tuberculosis is a disease that must be reported to the health department so that people who have been in contact with the affected patient during the infectious stage can undergo screening and possible treatment if indicated. The concept nutrition has the exemplars malnutrition, dysphagia, heart-healthy diet, which is cardiovascular, diabetic diet, malabsorption with his gastrostomy and enteral feedings, and failure to thrive. Nutrition is important to maintain health and to prevent disease and death. When illness or injury occurs, optimal nutrition is essential for healing and for resisting infection and other complications. Components of a nutritional assessment, there is a sequence of assessment parameters that may vary. However, evaluation of nutritional status includes these following methods: measurement of body mass index, or the BMI, waist circumference, biochemical assessment, clinical examination findings, and dietary data. The measurement of BMI and waist circumference is recommended to determine if a patient is obese. The BMI ratio based on base body weight and height. The obtained value is compared to the established standards. The BMI is highly correlated with body fat, although increased lean body mass or a large body frame can also increase the BMI. In nutrition, it's important to consider lifespan considerations. Adolescence is a time of critical growth and when lifelong eating habits are established. Nutritional assessment is particularly important during this time period. It is vital to assess for obesity in adolescents to prevent complications from obesity as they enter adulthood. Adolescent girls are at a particular nutritional risk because iron, folate, and calcium intakes are below recommended levels and they are less physically active group compared to adolescent males. Adolescents with other nutritional disorders such as anorexia and bulimia have a better chance of recovery if these disorders are identified and treated in the adolescent years rather than the adulthood. In nutrition, the older adult has a nutritional assessment that we must consider. Nutritional screening in the older adult is the first step in maintaining adequate nutrition and replacing nutrient losses to maintain the individual's health and well-being. Inadequate dietary intake in older adults may result from physiologic changes in the GI tract, socioeconomic factors, drug interactions, disease, and excessive use of alcohol, and poor dentation or missing teeth. Even older adults may be nutritionally at risk because of decreased odor perception, poor dental health, limited ability to shop and cook, financial hardship, and the fact that they often eat alone. In addition, reduction in exercise with age without concomitant changes in carbohydrate intake places the older adult at risk for obesity. There is an increased need for good nutrition, but a decreased need for calories. They also have a decline in renal function and a decreased ability to maintain fluid and electrolyte balance. In nutrition, the exemplar malnutrition is a concern. There are health consequences that are associated with malnutrition. Wound healing, susceptibility to infection, longer hospital stays, and prolonged confinement to bed. There are certain signs and symptoms that suggest possible nutritional deficiency, such as muscle wasting, poor skin integrity, loss of subcutaneous tissue, and obesity. These are easy to note because they are specific. Other physical signs may be subtle and must be carefully assessed. For example, certain signs that appear to indicate nutritional deficiency may actually reflect other systemic conditions, like endocrine disorders or infectious disease. Others may result from impaired digestion, absorption, excretion, or storage of nutrients in the body. Disorders caused by nutritional deficiency, overeating, or eating unhealthy meals are among the leading cause of illness and death in the United States today. Examples of health problems associated with poor nutrition include obesity, osteoporosis, cirrhosis, diverticulitis, and eating disorders. Within the concept of nutrition, there is cardiovascular as an exemplar. See page 732 in your Hinkle textbook, chart 27.1, titled Risk Factors, Coronary Artery Disease. Now, there are non-modifiable risk factors, and there are modifiable risk factors. A non-modifiable risk factor is a circumstance over which a person has no control. A modifiable risk factor is one over which a person may exercise control, such as changing a lifestyle or personal habit, or by using medication. A risk factor may operate independently or in tandem with other risk factors. The more risk factors a person has, the greater the likelihood of coronary artery disease. Non-modifiable risk factors are family history of coronary artery disease, increasing age, gender, men develop coronary artery disease at an earlier age than women, and race, higher incidence of heart disease in African Americans than in Caucasians. Modifiable risk factors include hyperlipidemia, and within that, low-density lipoprotein, smoking, hypertension, diabetes, metabolic syndrome, obesity, and physical inactivity. In the cardiovascular exemplar, prevention is essential. Controlling cholesterol abnormalities will benefit the patient in having less cardiovascular disease. The way we can control cardiovascular levels and the levels that we want is a low-density lipoprotein, or LDL, a high-density lipoprotein, HDL, low triglycerides, and a diet that has low saturated fat and high fiber. LDL is the target of current therapy because of its strong association with advancing coronary artery disease. The total cholesterol level is also a clear predictor of coronary events. High-density lipoprotein is known as good cholesterol because it transports other lipoproteins, such as low-density lipoproteins, to the liver, where they can be degraded and excreted. Because of this, a high HDL level is a strong negative risk factor for heart disease. It protects against heart disease. With continuing in the exemplar cardiovascular, prevention continues. Dietary measures. They provide recommendations of the therapeutic lifestyle changes diet, which is a diet low in saturated fat and high in soluble fiber. These general recommendations may need to be adjusted for the individual patient who has other nutritional needs, such as the patient who has diabetes. Physical activity is essential. Management of an elevated triglyceride level focuses on weight reduction and increased physical activity. Regular moderate physical activity increases HDL levels and reduces triglyceride levels, decreasing the incidence of coronary events and reducing overall mortality risk. Medications can be utilized if diet alone cannot normalize serum cholesterol levels. Medications can have a synergistic effect with the prescribed diet and control cholesterol levels. Lipid-lowering medications can reduce coronary artery disease mortality in patients with elevated lipid levels and in at-risk patients with normal lipid levels. Cigarette smoking contributes to the development and severity of coronary artery disease. A person who can have a cessation of smoking will decrease the risk for heart disease. Person at increased risk for heart disease is encouraged to stop tobacco use through any possible means, whether it be educational programs, counseling, consistent motivation, and reinforcement messages, support groups, and medications if needed. Managing hypertension is defined as blood pressure measurements that repeatedly exceed 140/90 millimeters of mercury. The risk of cardiovascular disease increases as blood pressure increases, and people with a blood pressure greater than 120/80 are considered pre-hypertensive and at risk. Early detection of high blood pressure and adherence to a therapeutic regimen can prevent the serious consequences associated with untreated elevated blood pressure, including coronary artery disease. Controlling diabetes is known to help prevent the development of heart disease. For many patients with diabetes, cardiovascular disease is identified as the cause of death. Hyperglycemia fosters dyslipidemia, increased platelet aggregation, and altered blood cell function, which can lead to thrombosis formation. These metabolic alterations may impair endothelial cell dependent vasodilation and smooth muscle function, promoting the development of atherosclerosis. The concept nutrition with the exemplar diabetes mellitus type 2 focuses on meal planning. Caloric requirements are based on age, gender, height, and weight, but the caloric distribution depends on carbohydrates, fats, proteins, and fiber. Carbohydrates should consist of 50 to 60% of the caloric requirements, fat 20 to 30%, protein 10 to 20%, and fiber 25 grams a day. With the concept of nutrition and the exemplar malabsorption, we'll be now discussing malabsorption with the infant or child. Short bowel syndrome is a clinical syndrome of nutrient malabsorption and excessive intestinal fluid and electrolyte losses that occurs following massive small intestinal loss or surgical resection. The most common causes of short bowel syndrome are necrotizing enterocolitis, small intestinal atresia, gastroschisis, malrotation with volvulus, and trauma to the small intestine. The extent of the malabsorption experienced by an individual is dependent upon the extent of the duodenal, ileal, or jejunal loss and the length of the small intestine loss, as well as the type. In malabsorption for the infant child with the short gut syndrome, nursing management includes total parenteral nutrition for long term, enteral feeding, administering vitamin and mineral supplements, administering antidiarrheals, and administering antibiotics per order. The child with short bowel syndrome is at risk for chronic complications. The goals of therapeutic management are to minimize bacterial overgrowth and to maximize the child's nutritional status. The antibiotics may be used to control that bacterial overgrowth. Vitamin and mineral supplementation is necessary because the small intestine is usually where fat-soluble vitamins, calcium, magnesium, and zinc are absorbed. Antidiarrheal agents such as loperamide and gastric acid suppressive medications may be used to decrease stool output. Many children with short bowel syndrome require total parenteral nutrition for extended periods to achieve adequate growth. Gastrostomy and enteral feedings are exemplar under nutrition. Gastrointestinal intubation is the insertion of a flexible tube into the stomach or beyond the pylorus into the duodenum or the jejunum. The tubes may be inserted through the mouth, the nose, or the abdominal wall. The tubes are obviously of various diameters and length depending on their intended use. The purpose of GI intubation may be performed in order to decompress the stomach and remove gas and fluid, lavage, which is flush with water or other fluids and remove ingested toxins or other harmful materials, diagnose GI disorders, administer tube feedings, fluids, and medications, compress a bleeding site, or aspirate GI contents for analysis. The different types of tubes depend on the diagnosis. Within these tubes, we do nursing management. We prepare the patient prior to the insertion to promote cooperation during the procedure. Once placed, we confirm placement. To ensure patient safety, it's essential to confirm the tube has been placed correctly. The tip of the tube may be in the esophagus, stomach, or small intestine. It may also inadvertently be inserted in the lungs, most commonly in the right main stem bronchus. Inappropriate placement may occur in patients with decreased level of consciousness, confused mental states, poor absent gag, or cough reflexes, or agitation during insertion. Also, what must be assessed is clearing tube obstruction. If it's difficult to instill withdrawal warm water into a clogged feeding tube, several declogging steps can be taken, including warm water penetration, milking the tube, infusing digestive enzymes, and employing mechanical declogging devices. When the tube is first noted to be clogged, a 30 to 60 ml syringe should be attached to the end of the tube and any contents aspirated and discarded. Then the syringe should be filled with warm water, attached to the tube again, and a back and forth motion initiated to help loosen the clog. Clearing tube obstructions is essential so that medications can be input or drainage can be expelled. Also, the nurse must provide oral and nasal hygiene. It is essential to have regular conscious oral and nasal hygiene because the tube causes discomfort and pressure and may be in place for an extended length of time. The nose is inspected daily for irritation and the tape is changed every 2 to 3 days. The nurse must also monitor and manage potential complications. Patients with these NG intubations are susceptible to a variety of problems, including fluid volume deficit, pulmonary complications, and tube-related irritations. These potential complications require careful ongoing assessment. There are also collaborative potential problems with gastrostomy and enteral feedings. There could be wound infections, whether it be wounds within the body or wounds at the site. Cellulitis, that is mostly at the site that there could be cellulitis of where the tube is inserted, whether it be nares, oral, or abdominal. Leakage at the site, gastrointestinal bleeding, and premature dislodgement of the tube. In the gastrostomy and enteral feedings, patient education is important. You can find a patient education chart, 45-7, page 1233, in your Hinkle ebook. Troubleshooting for mechanical difficulties is an intervention that should be utilized. Mechanical problems can arise with the infusion pump or catheter site. The patient should know the external length of the catheter, and the measurement is used as a comparison if dislodgement is suspected. The patient should also know a list of instructions on how to recognize catheter problems, including the leakage, loose caps, blood clots, and dislodgement, and what to do for each problem. Recognizing metabolic complications is essential. The patient is given a list of signs and symptoms that indicate metabolic complications like neuropathies, mentation changes, diarrhea, nausea, skin changes, decreased urine output, and directions on how to contact a home health care nurse or physician if these complications occur. Obtaining psychosocial support of home parenteral nutrition are as important as the physiologic and technical concerns, because the patients must cope with the loss of eating and with changes in lifestyle brought on by sleep disturbances related to frequent urination during nighttime infusions. So major psychologic reactions include depression, anger, withdrawal, anxiety, impaired self-image, and a successful parenting nutrition program depends on the patient's and family's motivation, emotional stability, and technical competence. With the concept nutrition, failure to thrive is an exemplar. Failure to thrive is a term used to describe inadequate growth in infants and children. The child fails to demonstrate appropriate weight gain over a prolonged period of time. Length or height velocity and head circumference growth may also be affected. Adequate nutrition is critical for appropriate brain growth in the first 2 years of life and obviously for growth in general throughout childhood and adolescence. Organic causes can be developmental disabilities. These may contribute to failure to thrive as the child's ability to consume adequate nutrition is impaired because of sensory or motor delays, such as with cerebral palsy. Other organic causes of failure to thrive include inability to suck and or swallow correctly, malabsorption, diarrhea, vomiting, or alterations in metabolism and caloric nutrient needs associated with a variety of chronic illnesses. Organic causes of failure to thrive may lead to behavioral problems that potentiate problems with adequate growth. Hence, failure to thrive is thought of as a multifactorial problem. With failure to thrive and the organic causes, there are at-risk patients. Infants and children with cardiac or metabolic disease, chronic lung disease, such as bronchopulmonary dysplasia, cleft palate, or gastroesophageal reflux disease are at particular risk. Feeding disorders or food refusal may occur in infants or children who have required prolonged mechanical ventilation, long-term enteral tube feedings, or an unpleasant event such as a choking episode. Inorganic causes of failure to thrive include neglect, abuse, behavioral problems, lack of appropriate maternal interaction, poor feeding techniques, lack of parental knowledge, or parental mental illness. Additionally, children who live in poverty are at risk due to the inability to provide adequate nutrition. Infants with failure to thrive related to maternal neglect may avoid eye contact and be less interactive than other infants. The concept elimination has exemplars titled Clostridium difficile, diverticulitis, inflammatory bowel disease, and Crohn's disease. With the concept elimination is the exemplar Clostridium difficile. Infection is usually preceded by antibiotic agents that disrupt normal intestinal flora and allow the antibiotic-resistant C. difficile spores to proliferate within the intestine. The organism causes pathology by releasing toxins into the lumen of the bowel. In pseudomembranous colitis, which is the most extreme form of C. difficile infection, debris from the injured lumen of the bowel and from white blood cells accumulates in the form of pseudomembranous or studded areas of the colon. The destruction of such a large anatomic area can cause severe sepsis. C. difficile is the most commonly identified agent in the antibiotic-associated diarrhea in the hospital. Assessment and diagnostics findings would include a complete blood cell count, serum chemistries, urinalysis, routine stool examination, and stool examinations for infectious or parasitic organisms, bacterial toxins, blood, fat, electrolytes, and white blood cells. Complications of diarrhea include the potential for cardiac dysrhythmias because of significant fluid and electrolyte loss, especially potassium. Loss of bicarbonate with diarrhea can also lead to metabolic acidosis. Muscle weakness, paresthesia, hypotension, anorexia, and drowsiness with a potassium level less than 3.5. With the concept elimination, diverticulitis is an exemplar. Diverticulitis results when food and bacteria retained in a diverticulum produce infection and inflammation that can impede drainage and lead to perforation or abscess formation. Diverticulitis may occur as an acute attack or may persist as a continuing smoldering infection. The symptoms manifested generally result from complications like abscess, fistula formation, obstruction, perforation, peritonitis, and hemorrhaging. The pathophysiology is the diverticula form when the mucosa and submucosal layers of the colon herniate through the muscular wall because of high intraluminal pressure, low volume in the colon, and a decreased muscle strength in the colon wall. Bowel contents can accumulate in the diverticulum and decompose, causing inflammation and infection. The diverticulum can also become obstructed and then inflamed if the obstruction continues. For the clinical manifestations with diverticulitis, the patient reports an acute onset of mild to severe pain in the left lower quadrant, accompanied by nausea, vomiting, fever, chills, and leukocytosis. This condition, if untreated, can lead to peritonitis and septicemia. Complications of diverticulitis include peritonitis, abscess formation, fistulas, and bleeding. For complications, the nurse must notify the physician immediately. Abdominal pain, a rigid board-like abdomen, loss of bowel sounds, and signs and symptoms of shock occur with peritonitis. For the medical management, diverticulitis can usually be treated on an outpatient basis with diet and medication. When symptoms occur, rest, analgesic medications, and antispasmodic agents are recommended. Initially, a clear liquid diet is consumed until the inflammation subsides, then a high-fiber, low-fat diet is recommended. In cases of diverticulitis with significant symptoms, hospitalization is required. While the patient is hospitalized, they will withhold oral intake, administer IV fluids, and institute nasogastric suctioning if vomiting or distension occurs, and this is used to rest the bowel. Medications like broad-spectrum antibiotics are prescribed for 7 to 10 days. Oral intake is increased as symptoms subside, and the low-fiber diet may be necessary until signs of infection decrease. The antispasmodic agents may be prescribed. Although diverticulitis usually subsides with medical management, immediate surgical intervention is necessary if those complications of perforation, peritonitis, hemorrhage, and obstruction occur. In cases of abscess formation without peritonitis, hemorrhage, or obstruction, a CT-guided percutaneous drainage may be performed to drain the abscess, and IV antibiotics are administered. With the concept of elimination is the exemplar inflammatory bowel disease. Inflammatory bowel disease is a group of chronic disorders. Crohn's disease, which is regional enteritis, and ulcerative colitis that result in inflammation or ulceration or both of the bowel lining. Despite extensive research, the cause of inflammatory bowel disease is still unknown. Researchers theorize that it is triggered by environmental agents such as pesticides, food additives, tobacco, and radiation. Non-steroidal anti-inflammatory drugs have been found to exacerbate inflammatory bowel disease. Allergies and immune disorders have also been suggested as causes. Abnormal response to dietary or bacterial antigens have been studied extensively, and genetic factors are also being studied. In the concept elimination, the exemplar of inflammatory bowel disease has two diseases, Crohn's disease and ulcerative colitis. Within these two disease processes, your ebook in Hinkle has a review chart, comparison of Crohn's disease and ulcerative colitis. Please review this chart and note the differences between the two disease processes. Management of chronic inflammatory bowel disease is medical treatment for both Crohn's disease and ulcerative colitis aimed at reducing inflammation, suppressing inappropriate immune responses, providing rest for a diseased bowel so that healing may take place, improving quality of life, and preventing or minimizing complications. The pharmacologic therapy includes sedatives and antidiarrheal and antiperistaltic medications, which are used to minimize peristalsis in order to rest the inflamed bowel. Aminosalicylates such as sulfasalazine are often effective for mild or moderate inflammation and are used to prevent or reduce recurrences in long-term maintenance regimens. Corticosteroids are used to treat severe disease and can be administered orally. Nursing interventions to include for inflammatory bowel are relieving pain. The nurse administers anticholinergic medications 30 minutes before a meal is prescribed to decrease intestinal motility and administer analgesic agents as prescribed for pain. Maintaining normal elimination patterns. The nurse provides ready access to a bathroom, commode, or bedpan and keeps the environment clean and odor-free. It is important to administer antidiarrheal medications as prescribed, to record the frequency and consistency of stools after therapy is initiated, and to encourage bed rest to decrease peristalsis. Maintaining fluid intake is also important. To detect fluid volume deficit, the nurse keeps an accurate record of I&O. The nurse monitors daily weights for fluid gains or losses and assesses the patient for signs of fluid volume deficit. Maintaining optimal nutrition. Parenteral nutrition is indicated in patients with inflammatory bowel disease with severe malnutrition and intolerance to enteral nutrition and are expected to likely remain intolerant to enteral nutrition for more than 1 to 2 weeks. Reducing anxiety can be essential. Rapport can be established by being attentive and displaying a calm, confident manner. The nurse allows time for the patient to ask questions and express feelings. Enhancing coping measures. Because the patient may feel isolated, helpless, or out of control, understanding and emotional support are essential. The patient may respond to stress in a variety of ways that may alienate others. Preventing skin breakdown. The nurse examines the patient's skin frequently, especially the perianal skin. Perianal care, including the use of a skin barrier, is important after each bowel movement. Monitoring and managing potential complications. Serum electrolyte levels are monitored daily, and electrolyte replacements are administered as prescribed. Evidence of dysrhythmias or changes in level of consciousness must be reported immediately. It is important to monitor the blood pressure for hypotension. The nurse closely monitors the patient for indications of perforation, the acute increase in abdominal pain, rigid abdomen, vomiting, or hypotension. Educating the patient about self-care is also important. In your ebook on chart 48.4, there is a home care checklist titled Inflammatory Bowel Disease. It will be essential to teach this patient so that they can maintain normalcy as much as possible for their disease process. They can verbalize an understanding of the disease process, discuss nutritional management, describe medication regimen, identify measures used to treat, identify measures used to promote fluid and electrolyte balances, demonstrate management of parenteral nutritional therapy, and incorporate stress reduction measures into the lifestyle.